Thank you. I will take but a moment to set up our study, give the background about why we did it, and then Barbara will talk about what the project is and what our findings were. First of all, we're transitioning from hospital-based care to residential-based care now. And when this work first started, it started with an ARC-funded project that was conducted in nursing homes. So the question is, why did we then translate it for implementation into assisted living settings? Well, here's why. Many of you, I'm sure all of you, are familiar with assisted living, but you might not know some of the statistics that accompany the shift that's happened in our long-term care settings. There's 15,000 nursing homes serving 1.5 million people. There's 40,000 assisted living settings serving almost 1 million people now. So 2/3 of our older adults who need supportive care are in assisted living. What do the residents look like? Well, we commonly say that the residents in assisted living look like what nursing home residents looked like 10 years ago. So these are people who are very impaired, who historically would have gotten a lot more attention if they were in nursing homes, but now they're in assisted living settings. Well, maybe that's okay if there's nurses there. Well, there's not. I mean, about half the settings actually do have a nurse, an RN, or an LPN on staff part of the time, but they're not at all required to be. So we have a lot of older adults who have a lot of impairment who are in assisted living settings, and there's not a lot of nurse supervision. Well, what about the CNA level folks? Well, they're not CNAs. They're personal care assistants. They don't need to be certified. So now we have even less trained staff who are attending to the care needs of these people. And then adding insult to injury in the sense of understanding these care systems and what people need is there's a huge amount of variability within all of the settings. Nursing homes are federally regulated, assisted living settings are state regulated. A lot of variability across states, a lot of variability within states. So really what this says is we are working now within a long-term care setting where there's obviously a great deal that needs to be understood, potentially a great deal that needs to be changed when one thinks about and starts learning about what those care systems are. Certainly room to implement quality improvement interventions and to evaluate them, and then to disseminate them if there's utility in doing that. And lastly, there's really strong provider organizations and policy organizations related to assisted living. And so there's a very good mechanisms to disseminate what is being found as this whole field continues to evolve. So that's why it was just so important for this project to be funded. We're very grateful that it was. And Barbara will tell you what we found and what we did.
First of all, I'm thrilled to be here because of the transition from acute care to long-term care. And just going back to this morning's conversation, please remember primary care is provided across all settings, which adds a different flavor to this morning's discussion. But I'm also want to remind those who are here for their first meeting that we in fact changed the name of our study because of the first meeting. I'm rewriting the restorative care book with the new title. I had to explain that to Springer. But we've really transitioned. I had to do a lot of talking with my team and folks that have used restorative care. But it is now officially function-focused care thanks to the Inquiry Project. So go figure. Although I really did like the analogy of restorative care for all rather than assisted living, which is, this is the assisted living section. So what is this project we did? And we're transitioning here as well because we did intervention work rather than some of the descriptive. And what we did in this study was we really used a comprehensive socio-ecological model to test the implementation of function-focused care. So to make this philosophy happen, the philosophy is really just quite simply geared towards getting nurses to think about care a little bit differently. Nurses tend to provide care for people. That's what we're taught to do. That's what consumers want for the most part. And think about what you want for your mother. It really may not, in fact, on first thinking about it, be for me to go out there and say, you're walking to dinner tonight. That's all there is to it. And that's what we're trying to get the nurses to think about, ways to engage people in optimizing what they can do and to increase physical activity. It's very much a two-tiered intervention because the first thing we have to do is change this philosophy. And given Sheryl's background of assisted living, think about what's going on in these settings, and then we're coming in and asking people to rethink how they have traditionally provided care. We do this by implementing 4 components. The first thing we do is look at the environment and the policy and procedures. Unfortunately, in this time frame, I'm not going to give you the gory details of what we find and what we do at that intervention level, but if anybody wants it, we have all of that in protocol-driven manuals. Then we educate the staff. Again, that's protocol-driven. Everybody, gets the same. We have the same process, same education. Then we have the staff and our function-focused care nurse develop goals for the resident, and then the big thing is the ongoing mentoring and motivating both of the staff as well as the residents. My focus of interest in research has always been on motivating older adults to engage in physical activity. So that is a big core of it, because in fact that's where 3/4 of the problem is. And for those of you sitting in this room, think about how many of you actually exercised this morning before you came to this meeting and are sitting here on our bottoms for the entire day. And think about why you did or you didn't. And therein lies a big part of the issue. And we use a social cognitive theory approach to do a lot of the motivational pieces. We included 4 sites. 2 were assisted living within continuing care retirement communities, and 2 were freestanding assisted living facilities. Just to give you a sense of who was in these facilities and in the studies, the direct care workers, which many of you may think of as the nursing assistants, but we refer to as direct care workers. They had to work for at least 3 days a week, and they had to read and write English. A total of 147 were actually employed in these sites, and of these, 96 were recruited, about 65% of all. However, 22% of those that we went to try and talk to and approach were missing in action already. They were either gone or, before. So from when we got the list to when we approached, so just to give you the bigger picture. And it was actually only 19 or 13% that actually refused, which is phenomenal. When we started doing this work, and Sheryl can remember, we thought that the nursing assistants would not play with us. They would not consent. And in fact, that's very much not been our experience. So to give you, rather than give you descriptives, I'm going to give you the picture of the direct care worker. The average direct care worker is female, African American, about 42 years of age, has 13 years of education and 12 years of nursing experience. She's got strong self-efficacy for performing function-focused care and generally believes in the benefits. She's got a relatively positive attitude about her job, fair knowledge of function-focused care, and when performing care, we actually do observations. When performing care, she engages in function-focused care interactions about 75% of the time. Bottom line here, a little sort of background issue with all of the research, we always recruit the best of the best, don't we? It's a killer for us. If you could recruit the worst and have that opportunity, we'd have even better outcomes. Just to give you a sense of the residents, 171 residents consented to participate in the study. To be eligible, you had to be 65 years of age or older, living in the community, and have a mini-mental of 11 or greater. So we excluded in this study those that were severely impaired. And then we also excluded those that were hospice. Just if they were not going to be able to play with us for the full year. Of the 494 residents that we were able to approach, to get a list with a name, okay, 123 of those were already deceased by the time we got there in hospice. discharged to the hospital, or simply non-communicative, or less than 65, which was surprisingly more than we realized. 177 residents or proxies refused to consent, and 185 residents did consent. And then we had to take out some because of mini-mental, a second-tier consentment. And I'd like to show you this, just so for those of you who don't work with this population, it's a major endeavor to engage them in research and something that has to be taken very seriously. To give you a sense of what this resident looked like, she was 88, white, female, widowed, had about 7 comorbidities. She tended to be pretty resilient, have few depressive symptoms, believed in her ability to exercise and perform functional activities, but didn't see much benefit to it. Had some gait and balance impairments, needed some help with activities of daily living, and engaged in only 0.36 minutes of moderate level physical activity and burned, this one kills me, 46 kcals of energy a day. That doesn't allow for much PO intake.
Can we stand up now?
Yeah. Exactly.
We can just walk in place, maybe.
Yeah. Or pedal. So what did we find? And I'm going to just share with you the significant findings. I just want to remind you, we are just reporting to you 4-month findings. This is the one study that I've done, and the reason why we have finished, but we're just doing the analyses now, and I didn't even want to try and do preliminary. This is the one study that I've done, though, that I really feel like our 12-month might be even better. And the reason for that you'll see, because I'm going to share with you a lot of our dissemination experience. It takes a while to get engaged in these sites, as you can imagine. And once the ball got rolling, it really got rolling. And I really do anticipate we'll see better things at 12 months. But what we found quite excitedly was that the direct care workers were doing more function-focused care. And we observed so that they were spending, in more of their interactions, more of it was focused on optimizing the person's function and physical activity rather than just doing the behavior. So we were really quite pleased with that. There was some significant findings as well with the residents. I want to report to you safety findings. For those of you that are the nurses in the audience, you know, maybe you don't if you don't work in long-term care, but the biggest fear is a fall or hurting somebody. So nothing ever gets done because we're petrified we're going to hurt somebody. And that's the biggest barrier that I hear from staff. So one of the exciting things was, yet again in this study, and we found it in other work, this is not going to hurt you. Okay, so it is safe. We don't have fewer falls, but that's okay. We're getting people moving, and we don't have more falls. There was no study-associated events. Nobody dropped dead from doing anything. And there was, in fact, a decrease in hospital transfers, a significant difference in the number of people that had to go to the hospital or got sent to the hospital from AL for reasons other than a fall. And my physiological theory behind that, and one that we can kind of flesh out of the data, is in fact that people have fewer infections. If you're moving, you have a less tendency to get pneumonia, urinary tract infections. And I just think it's pretty interesting. We actually added it as an outcome in some of our other function-focused care studies. Some significant findings with the residents, they all look like that. 12 months, there you go. Some of the significant findings were that there was increased social support for exercise in the treatment sites. Now that's a measure I use for treatment fidelity because what it tells me is that they were getting what we wanted them to get. People are talking to them more about doing it. There was also improved balance, as you can well see there, and improvement in walking 50 feet. That's a big deal in these sites. It means you can walk to the bathroom.